Um, Welcome to Ease of Research Department of Medicine Town Hall series. We are fortunate to have today Najarro, who I think everyone must know Gabe, right? I don't, no one has their camera on, so I was going to ask like who doesn't know Gabe? But anyway, um, I'll just my introduction is that he is the master of using Epic to harness Epic for research purposes. And is that accurate or is that?
Sure.
But he
Yeah,
he is he's an informaticist and he is the lead for the innovation and innovative recruitment strategies for the Georgia CTSA. Is a master of using electronic medical records for identifying people to recruit to studies and sort of how you can use the medical record to do your studies. And I think today he's going to talk about. I don't know. I mean, you can
yeah.
describe what
So
you're
we're
going
going
to
to talk
talk about,
about how
but
best to
real
use.
time engagement in Epic. I guess that's the
Thank you, Dr. Seuss.
message there. I guess right.
Yeah, and thanks. Yeah, so today we're going to talk about how we can leverage Epic tools and data to find patients better for your studies in a more timely manner.
All
And I
right.
appreciate
Perfect.
the intro. I do work with the Georgia CTSA Recruitment Center, Dr. Dickert, who's on the call as well, and Candace Spate, who's also on the call. And I'm also part of the physician informatics team under Emory Digital as a clinical and research informaticist. And I also still work clinically in the cardiac ICU at University Hospital. So I wanted to do a quick intro about the Georgia CTSA for those who don't know. It's the Georgia Clinical Translational Science Alliance, which is an alliance between Emory, Morehouse, UGA, Georgia Tech, and we provide a range of services from statistical support, epidemiology, research design, to regulatory support, navigating the research landscape, commercialization. And I'm part of the recruitment center with Dr. Dicker and Mugisha and Candace Spade as well. And this work is also supported by the CTSA Informatics Core. So some pretty key and very important members of the team, like Barney Chan and Megan Chwiney from the CTSA Informatics Core, who are also part of the Department of Medicine, I'm sorry, Department of Biomedical Informatics. So if you don't already know about the CTSA, please check out the Georgia CTSA website to learn more. And this is one of the services that we offer. So I'm gonna start with talking about recruitment being very challenging. I think everybody on this call knows, but it's challenging for a number of reasons. On the patient side, it's often difficult to gain trust from patients, and a lack of trust tends to be a big driver in patients not participating in research. Another challenge is that patients often find difficulty finding studies that might be most appropriate for them. On, on our side, on the researcher side, we have a hard time finding the right patients. And um, it's a pretty well-known concept that uh, on the order of 80% of clinical trials fail because they can't meet enrollment targets. And so this is a pretty big opportunity for us to improve what we do and how we do it when trying to execute clinical trials in our organization. One of the very first questions that people ask, researchers ask, is, well, who can I talk to about research? What patients can I approach for research? Before Epic, there was a policy in place called front door authorization, and that was a policy where patients would opt in to be allowed to allow researchers who didn't otherwise have a clinical relationship with the patient to contact them. So if you were a research team and you wanted to get a hold of somebody that you didn't already know about clinically, you would be limited by those patients who had opted in to front door authorization. Since Epic went live, we moved towards something called OK to contact. And it's a similar concept, but instead of being an opt-in for this OK to contact outside of a clinical relationship, now we're an opt-out, which means that the pool of patients that we can possibly reach out to has grown significantly. Within the EMR system, Epic that is, you as a researcher can go and figure out, okay, has a patient opted in? to this, or are they by default okay to contact? This I'll show you on the next screen exactly where to find it, but essentially you're presented with this snippet of information in Epic that says, is this patient willing to be contacted for research opportunities? This is, again, related to how uh, uh, clinical research staff can reach out to patients who you don't otherwise have a clinical relationship to. We're still operationalizing how this works, but this flag kind of facilitates the direct recruitment um, that you're allowed to do according to your IRB protocol. So um, the other important thing is that if you do interact with a patient and they are not interested in any further contact for any research studies, then it's important that we show them how to do that. And I'll show you where to find that. Within Epic, if you are a researcher and you're trying to figure out, okay, can I talk to this person if I don't otherwise have a clinical relationship with them? You can do that by using the search bar within Epic at the top to just search for research tools. And after you select that tool, you open a patient's encounter and you can scroll down to this research contact preference. This is the same area where you can see what other research studies a patient is enrolled in. And if you can't already tell, this is a fake patient from our testing environments. Um, for patients, they can set their preferences within their MyChart. So if they open up their MyChart and scroll down to the research studies activity here, there's a statement here that describes what permission to be contacted for research means. And that when they click OK, they're agreeing to be contacted directly by Emory Research if eligible for a study. Otherwise, they don't want to be contacted by researchers who they otherwise aren't involved with clinically. And so it's important for you as research study teams to make patients aware of this mechanism should they want to opt out of the system in the future. We're going to talk about a couple different recruitment methods during this talk. But just to review, there's a lot of different ways that we can recruit patients into studies. The most common is a clinician-led attempt. So, you're a provider or a nurse, and you know about a research study that this patient might qualify for, and you have a clinical relationship with them. You talk to them directly about that research study. Another type of recruitment method are community or digital outreaches, things like Facebook advertisements or attending community events and putting up a booth. Um, and then the last type of recruitment method, kind of broadly speaking, is these EHR-based cohort identification methods. And that's where we use the information that's available within the EMR to develop a cohort of patients who most closely align with your research study and try and target message them for engagement. So the two specific methods that we're going to talk about in this talk is MyChart for research recruitment and silent OPAs. MyChart is a great tool. It's a mechanism that provides private and secure and a familiar messaging platform, one that patients are, as I mentioned, already familiar with. And many patients may prefer electronic contact as opposed to a phone call. I don't know about you guys, but I have already set my phone to screen every incoming call because the amount of spam phone calls that I get has been overwhelming. And so MyChart offers us an ability to contact patients through a trusted platform. Um, and because we are already linked to the patient medical record, we can identify those patients who already have a MyChart account and use it to those who might meet criteria for a particular study. And by leveraging this mechanism, we can take advantage of the economies of scale, right? We can centralize this process of reaching out to patients so that patients don't get inadverted with too many messages for research. There are currently around 900,000 patients who have an active MyChart account within the Emory healthcare system. And this plot just shows a breakdown of age ranges and uh, gender. So we can see that the population does tend to skew a little bit more female and towards the older population. But this gives us a better sense of how broad of a population base that we can recruit from. When we send invitations to patients MyChart, it looks like this. Here's a MyChart screen, and they can get a description of the study and two quick buttons just to say whether or not they're interested. More specifically, what happens when we send an invitation is the patient gets a message into either their email inbox, and it says, you've been identified as a potential candidate for a research study, please log in, or they get a text message that says you've been identified as a potential candidate. And this is a really important message because we want to make sure that patients know upfront when they get a notification that this is related to research, that it's not some important clinical result or message from their clinical providers that they need to urgently log in for, that this is related to research. So we made sure that those initial messages were appropriately tailored. After the patient follows the link, they go into their MyChart, and right in the beginning, there's a banner. It says you might be a good fit for a research study. And when they click on that, they get a presentation of what that description of the study is and those quick buttons for I'm interested or no, thank you. And once they click a button, they say, thanks for your interest, and we'll be in contact with you soon. What we do is with study teams is work to optimize what that initial messaging strategy should be. Importantly, the patients are all told when they get one of these messages that based on your medical record, you've been identified as potentially eligible for a study. We don't want to say things like, you have this disease or you meet these specific criteria. Um, Instead, we want to keep things kind of broadly described. The patients are presented with who is responsible for this particular study in terms of a PI and a study investigator. And we work with study teams to optimize these messages so that they're relatively brief. Ideally, just a few sentences and a one or two paragraphs. This is not intended to be a full description of the study, but instead a call to action so that we can quickly get some interest from the patient. And this is based on experience from other institutions who've been doing this for quite a while now. The nice thing about these messages is we can also incorporate rich format text. We can incorporate images or links or barcodes, and we can do some additional formatting here. So it's pretty robust. From the studies team's perspective, when a patient clicks they're interested, they, within Epic, will get a message within their research recruitment folder, and they can open that patient's chart and do further screening and then reach out to that patient for consent and enrollment. So it's a pretty straightforward process from the study team's perspective. On the back end, what we do to make this work is that we leverage the Epic data warehouses. There's a number of names for these, but essentially we develop code against those databases to refine the population for whom we're inviting to a study to best match the inclusion-exclusion criteria for a particular study. And along the way, we do feasibility assessments with study teams. So here's an example of a study that was looking for patients with some specific criteria. And we were able to say, okay, well, of patients who have an active MyChart, who are currently alive and have not opted out of research contact and are within a particular age range and have heart failure, this is the number who have an ejection fraction greater than 45%. If we then, narrow it down to patients who haven't been invited to other studies or are not currently enrolled in another study, the number goes down and so on and so on. And so this is helpful for study teams to understand what to expect. In this case, we can only invite 924 people to your study. And so um, it's important to set expectations there. And as we go through that process of refining the cohort, we refine the code that we develop on the back end against the Clarity database. We translate that into a form that can be used within the Epic interface so that we can select patients and send the messages here. We've been doing this for quite a while, since the 2023, summer of 2023, when we first started. And since then, we've sent out 87,000 messages to patients. That's this brown line here. And we've seen pretty steady response rates here in blue. And the number of patients in green is those who've responded as interested as opposed to not interested in a particular study. If we look at that kind of as a proportion, generally what we see is somewhere between 7 and 10% of patients who ever get a message for any of the studies that we've done around 20 so far, will respond as interested. So that means that for every 1,000 invitations that we send out, a studies team might get 100 responses, which is many more than they would otherwise. And the other key thing is that these patients are responding with interest. They're responding with a very positive mindset towards participating in research, as opposed to someone you might encounter in the wild who has no idea or preference about research and may get otherwise disinclined to participate in research. Um, so this is a much higher response rate than what we see with other methods like social media. And so we think it's a pretty robust one. The other key thing is that patients respond very quickly. So this is a plot showing at time zero from the time that we send a message out to the time that a response occurs. Generally, we're seeing that within 24 hours, around 60% of patients who get a message will have responded. So if we send out 1,000 invitations on a Monday, you might expect 60 invitations or 60 responses within the first 24 hours. And so this is key because we've learned that we really need to titrate how many invitations we send out at any one given time so that the study team can keep up. Because the last thing we would want is for a patient to say, yeah, I'm really interested, and then not hear back from a study team for weeks, right? We want to make sure that that patients stay engaged uh, in that process. And we're interested in studying this even further. And we've actually published a paper last fall in Journal of Clinical and Translational Science, where we demonstrated what those response rates look like across different demographics. So this plot showed here the number of patients who received an invitation broken down to those who didn't respond at all, those versus those who did respond. And then the bars each represent what they did with regards to their overall research contact preference. So you've received an invitation for a study about cardiovascular disease. You've said you're interested, or you've responded, and afterwards you said, you know what, I'm also interested in remaining okay to contact for research in the future. So this plot helps us delineate that a bit more. And what we found is that of those patients who did respond in this group here, they were more likely to be white, non-Hispanic, female. They tended to have higher healthcare utilization in terms of the number of contacts and the number of comorbidities they had. And they tended to respond if the trials were interventional trials as opposed to observational trials. Of the patients who responded to those invitations, so this group broken down, this is the breakdown of those who responded as not interested versus those who responded as interested. The key here is that over 50% of the patients who responded as interested. And that's a great statistic because it shows just how engaging these types of invitations can be. And then furthermore, the patients who responded as interested were much more likely to say, you know what, I'm interested in staying eligible to be contacted for other research studies. And so that allows us to demonstrate that by engaging these patients, we can encourage further participation in research. And then in terms of demographic breakdown in this evaluation, this was a year and a half ago, 2 years ago now. Patients who were more likely to express interest were actually males, were non-white, and they also had higher healthcare utilization and were more interested in interventional trials. So this was just one example of what we want to do going forward. We want to continue to evaluate what the best practices are here and to publish on that. And we're not the only ones. One of the study teams that we worked with, Dr. Zaveri and Dr. Alvarez, for one of their cystic fibrosis nutrition studies, also found that this was a fantastic way to enroll patients and screen for patients for this study. They were able to get significantly more amount of patients in a given time period using this method versus traditional verbal screening. And then to branch off of that, we are also working with the Better Center out of UPenn as part of an AHA strategically funded research network project, where we're trying to answer the question of what messaging strategies are most effective. We're going to measure the overall rate of interest and rates of enrollment versus those of patients who respond as not interested, and see what happens as they change their contact preferences over time. Essentially, what we're going to do is we're going to randomize patients to receive one of 4 different message types, and we hope to send out about 75,000 of these per year. So to dive deep a little bit further, what we're going to do is as we work with study teams, we're going to develop 4 different versions of that initial message. One, which is just a basic message. One that includes some detailed compensation information. One that includes positive framing within that message, and then one that includes both to better evaluate what works best for generating interest in a study and ultimately leads to higher enrollment. And this is a question that I think is really important because there are some default rules on what those messages can look like from an IRB perspective that we want to make sure is backed by actual evidence. Of course, nothing comes for free. There are limitations in how many invitations we can send out to patients. Right now, the system limits us to sending no more than 2 invitations to a particular study to a particular patient, and to limit those to no more than 1 invitation per month. And ideally, we would only send one total invitation to one patient for one study. And that's because we really want to make sure that we don't burn out our population of patients that we can invite to other studies. So occasionally we will allow more than one invitation to a particular study if the overall pool of eligible patients is relatively small. But ideally, we'll limit how many invitations go out to patients. And this is again ties back into our goal of centralizing this process so that we don't turn that big pool of 900,000 patients down to something much smaller like it was before we went to an opt-out scenario. Um, Research recruitment is always evolving, and the next step is a new tool from Epic called Campaigns, which helps us to automate this process of sending out the messages. Right now, the way it works is myself or my cohort Mugisha will log into the system, run the reports, and send out the batches of messages, and we run our own logs and keep track of everything. But ideally, with this new platform offered within Epic, we can automate that and we can do things like prioritize which types of patients we focus on sending messages out to first, using a high, medium, and default priority mechanism. And then we can automate these with very specific time intervals to send out invitations, limiting how many messages go out in any particular phase of recruitment. So we're currently starting to test this, and we hope that this will help automate the overall process. If you haven't already noticed, there's been a QR code at the bottom of most of the slides you've seen so far, and that's a QR code to our intake form, which I'm also going to put here in the chat. This is our general intake form. We first developed this just for the sake of MyChart recruitment, but it gathers all the necessary information in terms of the details of your study, how many patients you're looking to enroll, how quickly you anticipate your study team could respond to messages. Um, is your study already IRB approved? Or are you still in the planning phases? Is your study within the clinical trials management system Encore? Or is that another step we have to take? So there's a lot of things that we need to do as part of the intake process, and this is the best way to get started if you're interested in using MyChart for research recruitment. And I'll put this QR code up again at the end of the talk. So that's MyChart for research recruitment. Um, Before I go on to the next type of recruitment, does anybody have any questions? Okay. So the
Wait,
next,
Gabe, I'm sorry.
yeah,
My connection dropped off there. I would just wanted to ask about in the initial messaging, do you don't talk about like incentives, like the maybe a monetary incentive that's offered, or I don't know if you covered that. I
yeah. So it depends on the study. If there is specific monetary compensation, we can mention that. We try to keep things as brief as possible. But what you're highlighting is something that we want to test, and that's part of this Osprey trial that I mentioned, which is this platform trial that Dr. Dickert is setting up, so that we can test which of these messaging strategies, those with detailed compensation information versus those without, those with a
okay.
positive framing of the language versus those without, because we need better evidence as to the impacts of including compensation details within that initial messaging strategy.
And this strategy, what if you want to recruit from the Grady healthcare system?
Good question. We are not live at Grady to do this. Right now, we're only live at Emory. Conceptually, we should be able to do these things at other institutions like Grady or CHOA. But the big um, catalyst for us being able to do this within the Emory system was this transition from an opt-in for research contact to an opt-out for research contact policy that we had system-wide. Right now, I think Grady is an opt-in for research contact, and so their potential pool of patients that we could send invitations to is likely very small. And so really the first big hurdle that we need to cross with regards to Grady is is enabling this opt-out for research contact for their patient population. But all of the mechanisms in terms of developing the cohorts against the databases, developing the reports within Epic, sorry, I'm jumping around here, developing the reports within Epic um, are the same because it's still Epic, right? So it's really that first hurdle that we need to get over, and one that we're hopeful we can do this year.
And I'm sorry, the other healthcare systems in Georgia, are
I,
they using this strategy or?
I'm not aware of any in Georgia that are using this. But to be honest, I haven't looked in detail at one of the institutions. When we first developed this program, we use our experience from talking with other CTSA groups from Johns Hopkins and Yale and MUSC who have been doing this for a while. And there are some of these groups, I believe Yale has given a presentation at the annual EPIC conferences where they've sent out over 1 million messages because they've been live for many, many years with this mechanism. But in terms of Georgia, I'm not aware of anybody else in Georgia using this
So
mechanism.
I'm just thinking about Houston
Oh,
healthcare.
oh, right. So now that Houston is part of Emory, then that would include that patient population as well.
Okay.
Yeah. Um, so yes, under the Emory umbrella, then
Yeah.
this would still apply.
Yeah. Okay.
All right, so the next type of research recruitment that I'm going to talk about is something called Our Practice Advisories. You may have heard about this type of platform before called Best Practice Advisories. Epic changed the name, so now we call them OPAs. And as a clinician, you might be familiar with these OPAs. These typically show up as pop-ups for things like drug-drug interactions or recommended al altering of medications given formulary limitations or recommendations to add specific orders for other therapies. But that type of OPA is not what I'm going to talk about. This is what a traditional OPA looks like. And those are meant to be interruptive. They're meant to stop a user from potentially causing harm or having a negative outcome. What I'm talking about are called silent OPAs. And these are ones that will run in the background discreetly. And they'll result in an in-basket message to a focused group of people, like the study team. The impact here is that, again, we don't disrupt workflow. We only include a very small number of people who this would affect. And so those key features help us get these types of things built out within Epic much faster because it's a much more streamlined governance approach. Traditional OPAs, like the ones I showed on the previous screen, tend to take a lot of build time and a lot of governance because of the number of people who could be impacted by an interruptive OPA. But for silent OPAs, we're able to move a little bit more nimbly. The way OPAs work is the Epic system um, takes in a trigger event, it evaluates some criteria, and then it takes an action. And so for our silent OPAs for research, we look at things like triggers like when an order is entered, or when a lab is resulted, or when a diagnosis is added to the patient's chart, or events get scheduled. When one of those triggers occurs, then the system will evaluate criteria in the back end. And these are the kinds of criteria that we align with your research study inclusion/exclusion criteria. When a patient meets positive or evaluates the true for all those criteria, then the mechanism in the background will assign that patient to the research study with a pre-consent status, one where we just say that the patient has been identified, not enrolled or anything, just that we've identified the patient with the study for the study, and then we notify the study team. And so we notify the study team in their in-basket. So within Epic, within your research recruitment folder, you'll see a similar line item for a patient who met criteria. And you'll see a little message. This is a potential candidate for your study. And you can go in and do further screening. So this is really helpful because it is real time. So whenever one of those triggers occurs, the criteria will be automatically evaluated, and then the message will get automatically sent to the study
Oh,
team. So this mechanism is much more robust when it comes to studies that require that a patient get enrolled within a very specific time frame after a particular event. So, for example, a COVID study that would need to enroll patients who, uh, you know, tested as soon as they tested positive, they want to get them enrolled into a therapy, or for studies of patients who are currently admitted. right? As soon as someone's admitted with particular criteria, we want to make sure that we know who that patient is as fast as possible. So this mechanism works well for that type of recruitment pathway. And I saw Neil just came off camera in case he had any additional comments.
Oh no, I was just not moving anymore. So
Um,
demonstrating my engagement.
yeah. So nothing comes for free. OPAs tend to be a bit more time consuming in terms of the amount of time it takes us to build these out and get them into the production environment. And as the criteria become more and more complex, it adds to the development time because these are much more difficult to test and validate than our approach with MyChart, which is a SQL-based, a code-based approach. With OPAs, we're limited to building out these criteria within the Epic interface, which isn't a code type of interface. Um, and so those are the challenges with building out OPAs. And regardless of what mechanism you go through, whether that's MyChart for research recruitment or silent OPAs, there's always a lot of factors to consider about what is the best mechanism. Factors like what is the overall pool of potentially eligible patients in terms of size? How complex are the study criteria, and which of the study criteria do we need to prioritize? Because it's not every single study criteria that we can evaluate in a programmatic, computable phenotype way. There's lots of study criteria that are subjective, and those are very difficult, if not impossible, to program out easily. Other factors like time between eligibility and enrollment, like I mentioned, and that's where OPAs tend to become more of the pathway to take. The study team capacity for enrollment. So as I mentioned when I was talking about MyChart recruitment, because people respond very quickly and we see a pretty large response rate compared to other recruitment methods, we need to make sure the study team has capacity to respond to the potential amount of patients who respond as interested so that we don't delay that amount of time between a patient saying, yes, I'm interested in your study, come talk to me, and the amount of time and the time with which the study team can actually respond to them again. And then, of course, things like demographics and the types of intervention that is included in that study. That's where we bring value to the table. We've having had experience doing this, and where we value the input from our data analysts on the Department of Biomedical Informatics side, who are good about translating these subjective criteria into computable phenotypes. But a lot of people are always asked this question, which is what about unstructured data? What about the data that is what we would consider the ground truth that's contained within clinical notes? And that still remains a challenge. However, in the evolution of research recruitment, Epic is developing a tool, a generative AI-based approach to evaluating study criteria for patients. And so this is not yet live. This is still in the development phase. We're hoping to do some testing with this this year. But essentially what this does is it ingests the inclusion-exclusion criteria your from clinicaltrials.gov or manually entered criteria, and then we'll go and evaluate patient notes for each of those criteria. So in this screenshot, you can see the criteria of insulin-treated type 2 diabetes. Well, here is Epic's response after doing large language model evaluation of all the notes and a citation for where it got that information, whether that's from a particular medication or a problem list or a progress note, et cetera. So this might be a big win in terms of being able to evaluate that type of unstructured data that's contained within progress notes. But of course, we need to evaluate to make sure that there aren't unintended biases towards particular demographic groups or other unintended consequences. That's what we're currently evaluating. And then the last thing, as I've said before, nothing comes without a cost. And that's because, as I've probably already demonstrated, that this takes a lot of work. To get started with the CTSA, building out MyChart recruitment or silent OPAs, we have a startup fee of $1,000, and that covers the efforts that it takes to get these out. And for MyChart recruitment, we'll cover us sending those ongoing messages. If along the way you decide, we've been trying to evaluate all these, we're trying to invite all these patients, the ones who've expressed interest are still not eligible because of XYZ criteria, can we go back and change the code a little bit to be a little bit more specific? Then that we would have to do some additional changes to the code and charge some additional fees. However, if you are interested in partaking in the platform trial that I described, the Osprey study, where we test different messaging strategies, then with the funds from that study, we can waive these fees of getting started up. So if you are interested in partaking in that and are interested in using MyChart for recruitment, please reach out. And here's that QR code again. So to wrap things up, I think we bring a pretty significant value to our researchers across the system, and we're here to help. And you can get a hold of us either by going through the CTSA website, through my email, which I'll put in the chat, through our intake form, and we're happy to talk more.
Thank you, Gabe. Um, the we're open for questions for Gabe. And I guess
I see Dr.
Well,
Keshup put a comment
yeah.
in there. Thank you, Dr. Keshup. Yes, these things are all very sensitive issues, and we have tried to, things like childbirth and pregnancy are always challenging. We've seen that, right? We can try and recruit patients who have a pregnancy code, but we may inadvertently recruit patients who've had a miscarriage, and that would be unfortunate. And so we do everything we can to avoid those scenarios. But yeah, those are the kinds of considerations that we make as a centralized team to avoid those scenarios.
Yeah, I would just add two quick things. So one along the same lines, one of the values of kind of working with this with the group is that there's been a fair amount of accumulated experience in terms of using search criteria that may be more refined than just the inclusion exclusion criteria, right? So thinking about, for example, if you have a cardiovascular study, you could either focus on anybody who had some sort of condition, or you could have a bit of an enriched population and focus on people seen within cardiovascular specialties, for example, right? And that may change your yield. And we're pretty good at working with people to kind of think through strategically what makes the most sense, so that we're having the right kind of ratio of people who are appropriately eligible. The second piece I'd add, I put it in a comment, but just to kind of amplify something Gabe said, the permission piece about research contact that only applies to people to whom you don't have a direct relationship. So if you're part of a team taking care of a patient, you're doing a study, and you see that patient's chosen that they don't want to be contacted about research participation, if you already have a relationship with that patient in some other context, that does not mean you can't talk to that patient about research. We've had some questions about that at times. So that this does not in any way impact, and it says that, does not impact your ability to talk with patients that you would normally have a relationship, whether that is a pre-existing research relationship or a clinical relationship. So that's important, because we've had sometimes where we've had coordinators say, well, I'm not sure I'm allowed to contact this patient because they say they don't have they've opted out of that, but that's not the case if those provisions apply.
Okay, I'm going to speak up if no one else is for right now. Gabe, you showed for the MyChart approach, you showed some graphs where the lines, the number of messages are going up exponentially. Oh yeah, there we go. And then the responses are going up, but the red line there is the enrollment.
Yeah,
So you said 7 to 10% end up enrolled
no,
in no.
no. Thank you for highlighting this. And I purposely left out that qualifier for that red line. So 7 to 10% of the amount of patients who respond as interested.
Yeah.
They get the message, they read the message, they click that button that says, I'm interested. We have been able to use that metric to really show how successful this is towards engaging patients in research. But you're right. The next step is, well, how many got consented? How many got enrolled? We are limited in our ability to make that evaluation because of the time delays and how uh, because of the time delays that study teams have when logging those patients as consented enrolled within the Encore system. So these numbers that you see here are all dependent on how many patients the study team actually consents and enrolls, and then logs that patient within the Encore system. There's
So it could
some
be
teams are great about
underestimating.
doing that. Some teams
Yeah.
have delay.
So you think that
It's
number is underestimated there, I guess. Is that
Yes. Yeah.
massive underestimate. Yeah, massive underestimate.
okay?
We want to make that better. The challenge, and the other thing I would add is that there are sometimes, and sorry, Gabe, I didn't mean to speak for you on this. You know it better than I do, but there's also teams where we use an encore. We create a sort of encore shell. So, for example, observational studies for which people wouldn't otherwise even have to be registered in encore. Those people will never. We just don't have a way to track what in the
Okay.
same system whether they're enrolled or not. So yeah, there's all sorts of reasons, some related to delays, some related to workflow issues. That number's we should probably take it off the graph because it's just a distractor. We want that number we want to get that number and we want it to be accurate. But the graph is not, it doesn't really tell the story as of yet. Within the Osprey trial, for what it's worth, we will work with teams to periodically check in with them and get those numbers. And we're putting in place some mechanisms to try to make that more robust so that we do have a sense of the conversion rate from contacted to interested to enrolled. So within those studies, we will have a much more accurate sense of how that translates.
Yeah.
Uh,
The other limitations with these plots is that some of these patients have been invited to more than one study. And so that affects, this analysis, and we're working through that to make it a
Yeah.
more robust analysis.
okay. Um, so the Osprey is you would have a study within a study for if you got involved with Osprey. Is that what you're saying? Like you have a study that you were trying to recruit, but
Yeah,
then you're
yeah,
within the Osprey study.
yeah. Gabe, do you want me to respond to
Yeah,
Osprey?
yeah, yeah.
I mean, you know it is, again, most things you know better than I do. This one maybe we know equally well. At any rate, so Osprey is, so Charlie, that's exactly right. So it is a platform. It's set up as a platform trial, which is interesting. But basically, if you are a trial, or it doesn't have to be a trial, if you're a study using the MyChart mechanism and you agree to participate in Osprey, we create 4 different messages that differ only in the parameters that Gabe described. Patients who get contacted about that study will be functionally randomly assigned to one of those 4 messages. We do it by the last 4 digits of their MR number, which is functionally randomly assigned. And yeah, they'll only get one version of the message. So yeah, it's a study within a study. There is no separate if you're using Osprey, the IRB has approved the Osprey trial, so you don't need to go through any separate layers of regulatory approval or anything like that. You just submit the 4 messages and you say we're part of the Osprey trial, and the IRB knows that is that's what's going on. So they have approved our study. We've also initiated contact with Advara and WCG. So for what it's worth, people using independent IRBs, that's also worked out. So those are not barriers. So if you're a local site, you're participating in Osprey, and the study is overseen by Advara and WCG, for example, we can also work with that.
So on this slide, for example, I see the Grady logo.
Grady's part of the
I-
Better Center.
Is that is that a way to get into MyChart recruitment for Grady?
No. So yeah, so the Better Center is an AHA funded SFRN that
I
Modele and
see.
I
Okay. Okay.
are co-PIs for, and we're the PIs for the Osprey project. So yeah, this doesn't have anything to do with an entree into the Grady system. That said, especially I don't see Modely, I don't think is on this call, but we are very interested in having conversations with Grady administration. And it really is an administrative decision about the shift towards more of an opt-out method for research contact. And we're hoping that the initial experience within the Emory system will be a nice basis for being able to move within the other systems that we touch, move towards that. Because as Gabe said, the technical capacities for doing this are are translatable. We just have to have the functional pool of people that we can contact to make this worthwhile.
Dr. Kashyap.
Yes, thank you, Gabe, for providing this excellent summary. And the question of Grady patients and recruiting them for studies comes up often. And it also translates into some operational questions. Well, oh, I practice at Grady. Could I get my Epic data this way? One of the things, of course, is administrative that Dr. Diker already addressed, whether they follow the same practices for allowing opt-in versus opt-out. The second is technical. Yes, while the skills are shareable, they are an independent organization. They are on a very separate instance of Epic, which has different versions and different administrators. So we are happy to, and Gabe, let me know if I'm speaking out of line here, but I'm pretty sure at Emory we are happy to share our knowledge with other colleagues, but it would be on their leadership to take and build while we're there to support them.
That's right.
Absolutely.
Yeah.
Very helpful addendum. Yeah.
Yeah.
I
The
mean,
operational difference is key there.
I'm sorry I'm beating this I'm beating this topic up, but it just strikes me that Morehouse, which is part of the CTSA, right, does a lot of recruiting out of Grady. I mean, there are Emory investigators also down there, right? So it's curious to me, I guess, why, there's this. I mean, I understand. Based on what you guys are saying, I understand why there is, but that's what that's what piqued my interest here. Um, so I'm I don't want to monopolize. We still have you for 10 minutes, so I'm just
Yeah, and beyond that too, please reach out to us in our group.
yeah.
Dr. Trammell looks like a
I have a few more questions, but I want to let other people speak.
I, I just wanted to ask because you mentioned the regulatory piece. So if you're planning a study now or you have a study that's already IRB approved, are there specific things to include in the recruitment plan that allows you to use this MyChart recruitment strategy? Or shall I say, should you be more vague in how you can identify patients and contact them?
No, we have some templated language that you can include in your protocol, and we will work with study teams to develop those messages that you can include as your recruitment materials. We work pretty closely with the IRB. We have regular journal clubs with them, and we talk about other issues. So they're aware of this service that we're offering. So I think it's important to say you're working with the Georgia CTSA, and again, as we onboard study teams, we help them develop those materials.
So to follow up on
Yeah.
that, go ahead.
Right. I was just going to say, with regard to the plans for contact, I think if you should be as the main thing is just outline the plans you have for recruitment, and if it involves getting patient data from us, or using, for example, recruiting based on the presence of people not having opted out, if they're not people that you would otherwise have a clinical relationship with. It's important, just as it would always be, to sort of specify that for the IRB. We are working with them to help to kind of operationalize that in terms of kind of contacting people that you don't previously have a relationship with. From a regulatory perspective, it's okay. They just, like anytime, they need to know how you're doing it. And it's a bit of a shift from what they've done previously, but we're working with the IRB to figure out the sort of right use cases, and kind of, it's more of really a best practices approach to when we're reaching out different ways. They've been very supportive of the MyChart mechanism, and that's in part because that's a nice tool because it's coming within a trusted system, rather than random phone calls or those kinds of things. And so it's one of the reasons it's been a nice way to kind of grow that experience.
Yeah, and as part of that process, we aren't exposing the research study teams to patients who aren't otherwise interested in their study. And so I think that's a big win in terms
Yeah.
of minimizing the amount of PHI exposure.
Yeah.
Hi, Manju.
Hi, Gabe. Thank you for this session. It actually gave me a lot of insight since we're using your MyChart. So for us, we've been using MyChart since 2024 now, and we've had a great experience with it. I just wanted to share that it's been more useful than us mailing in for recruitment. That's what we had previously used. And I did have a question on the generative AI that you had mentioned. Um, I think we did talk about this previously with regard to identifying all the other details about the participants. Yeah, so my question here is, when is this going to be rolled out? I know it's too soon to ask,
Yeah.
but I just wanted to find out since I feel like it would be really useful for us in terms of recruitment since I identify more when I actually go through the progress notes. So
Yes, you are 100% right. And I completely agree with your excitement because the ability to make these kinds of evaluations much quicker would save on recruitment times pretty significantly. This feature is currently basically in beta testing. Um, we don't yet have access to this feature in our testing environments within Emory. We're working with leadership to make that happen. And then the goal would be over the next 6, 8 months to do a robust evaluation to make sure that there aren't significant risks and maybe, you know, a very big maybe, get this into a production environment where we can get study teams access to this kind of evaluation tool by the end of the year. But we have some administrative hurdles to cover.
okay, that would be great. Okay, thank you. And we are excited to start on the Osprey study as well. So hopefully that gets up and running soon.
Yeah, and we
Thank you
appreciate your
guys for your
partnership on that.
partnership.
Yeah,
Of course.
yeah. So
Thank you, Dr. Rickett.
for those that don't know, Manju is part of a few different studies that have been using MyChart recruitment for quite some time, as she mentioned, and they've been big partners with us.
And they've been suffering through the initial hurdles of getting Osprey up and running, but I think we have crossed those hurdles now, and then hopefully are ready to roll.
Oh, actually, one of our studies, I just met with them, so Transform, and it does look positive now. Hopefully, we can get that running by next week. So,
Awesome,
Great.
awesome. Thank you.
thank you.
Yeah, and we think we mentioned this with regard to Osprey. Obviously, it's something we're excited about. We set it up as a platform trial, so what this means is that basically the protocol will allow for iterations as we gain experience, right? So the first year or so, we're planning to compare these four approaches with the idea that we're going to get about 75,000 or so messages with people randomly assigned to one of four. But the way it's set up is we have a common set of outcome metrics that we would want to look at, and we could change the nature of the messages after that and do new comparisons. We could incorporate other aspects of the workflow related to MyChart recruitment. There's a lot of permutations that could be set up. And so we've kind of set this up as a trial that will allow iteration as we learn what tends to work. And importantly, we're looking at not just what it does to overall interest and enrollment, but we're looking at how different approaches to communication impact different patients, defined by healthcare utilization, age, race, sex, rurality, all the things
Location,
that we know can be. Yes.
like rural versus
Yep.
urban.
Yep. That's one of the specific things that we're going to look at.
So I know we're running out of time here, so I just want to maybe summarize a little bit. So the MyChart approach is live and validated and running. The OPA approach is sort of still.
I would say that we are accepting studies to, figure out if it's a good mechanism for them. I've built 5 of these so far, 5 OPAs for 5 different studies. And what we need to figure out is kind of what is the average amount of time for a given study to go live with one of these OPAs so that we can understand what that effort requirement is from a cost perspective. We have a general sense right now, but as I mentioned, building those out is a different level of complexity. And so we just need some more experience as opposed to MyChart, which we've done, I think, close to 20 studies now. We know what that operation looks like. But they're both live.
So if you are someone who's writing a grant right now and is proposing different methods of recruitment,
Come work with us. Meet with us. We'll talk about your study criteria, what might be the best recruitment method for your particular study, and given
okay,
intervention, observation,
and you provide language for the grant application.
that's right. That's right. We can
Yes.
do that.
Okay. And you're not just recruiting white, middle-aged women.
Correct.
Unless
Correct.
unless you have a study that only focuses on that population.
But Gabe was saying that's what what you're
No.
getting a lot, right?
I think
Yeah, that's not true.
Okay.
those
All right.
those are the
Gabe,
patients who
correct
are more
Charlie.
likely to respond.
So,
Okay.
Yeah. Um,
trivially though, so I think it's important, like it's not a huge difference in response rate, but that is offset by when you look at the patterns of people who respond, whether they're more likely to be interested, that sort of reverses that trend. Right. So in the end, the difference in uptake among most categories is not that different. They're really small.
Okay.
yeah.
All right.
So
And we can target a particular demographic, but it's important to note that the overall patient population within our system tends to skew more female, right? And tends to
Yeah.
skew more between the ages
yeah,
of 35 and 85, 75.
Okay.
yeah. The major take home for this is that for most of our that relatively speaking, this does not seem to be a very selective method of recruitment, which is a good thing. Right, that we were worried about that, and that has not materialized as far as we can tell.
Okay.
Minor differences in likelihood of response, and then kind of basically offsetting differences in whether that response is likely to be a yes.
All right. Well, we're at the hour. Thank you so much, Gabe.
Yeah.
Thank you. And then Dr. Dickert, thanks for chiming in here for Osprey. And yeah, I think these slides will be available on our website, I think, at some point. So um, that was incredible. Yeah, it's inspiring. Thank you very much.
Thank you. And
Thank
thanks,
you
Jacob,
guys.
for putting my email address there in the chat for those who need it.